Hello, how are you? I hope all of you are okay. I am Dr. Sebastian, and I'm going to present you the seminar number 10 that it's about preeclampsia. It's a very common topic. The 7% of the pregnancies have some kind of disorder with the hypertension. And to manage this is very complex. We need to know a lot of different ways of management, different pillars of management, monitorization, etc. So the aim of this class is to summarize everything in order for you to give your tools to treat this patient in a correct way and in the appropriate moment. But because there are some times that these patients that with severe issues come for the ward and we're not able to manage them because we don't know what to do, and we wait until the other day. We wait until the round in the morning and the consultant say to us what we have to do. But we're trying now to give you like the special tools, the special knowledge, the important part of what to do in what situation, so you'll be able to treat this patient before, and we don't risk this patient to unnecessary risks that we can prevent before. So the objectives of this class, we will answer all of these questions. It's a lot, but I hope we can do it. First, we're going to talk about what is preeclampsia, what happened in the preeclampsia, like the physiology, pathophysiology, simplified. Then how to diagnose the preeclampsia, that we need special points to diagnose that. And after diagnosing, we need to classify them because that will be useful for categorize the severity of the preeclampsia and the treatment. After that, we will talk a little about the preeclampsia prevention, the preeclampsia approach, like with a patient with preeclampsia, how we approach this patient, the examination, the clinical history, okay, and of course the laboratory tests. Then we will talk about the treatment, divided in 5 important pillars. And at the end of the presentation, we will show a little how to administrate magnesium sulfate and what is the utility. So this is the first important question that we need to answer, that is, what is preeclampsia? Preeclampsia is a very common disease that have relation with the placenta. There is some issue, some problem with the placenta that cannot afford to give the nutrients, the oxygen, the glucose, and all the things for the baby to grow. So there is a problem with the placenta that make a change in the mother's body, and also it's a risk for the fetus. So here we can see a drawing of a fetus asking for food, ordering pizzas, asking for food for the mother, but the placenta cannot afford that. So what is preeclampsia? In a more sophisticated answer, it's like a widespread vascular endothelial malfunction and vasospasm that can start after 20 weeks of pregnancy and can present until like 6 weeks after the delivery. Have a lot of fetal and maternal mortality and morbidity, and have also important complications like abruptio placenta, cerebrovascular accidents, organ failure, coagulated disseminated coagulopathy, disseminate intravascular coagulopathy. Also, well, it's a very severe disease, and it's caused by the placenta, that is very important. It's progressive, multisystemic, and have a very difficult management because there are 2 lives at risk, the mother life and the fetus life. So we need to take decisions based in that, and that is the more difficult part about this disease. Okay? But the unique definitive treatment is the delivery. Why? Because this is caused by the placenta. So we need to take away the placenta to treat completely the disease. Okay? An important characteristic is that it's progressive. That once it starts, it cannot improve. It always gets worse or worse or worse. So what is the impact of this disease? The impact in numbers here in Kenya is important because it's the 3rd cause of maternal mortality. Okay? The 13% of all the maternal mortalities are because of preeclampsia. That means that 47 mothers every 100,000 die every year because of preeclampsia. These are numbers of the NCPD department of Kenya. So what happened in the preeclampsia? Like the pathophysiology, to understand this, we need first to understand what happened in the normal pregnancy. The placenta, as we know, is a foreign tissue. So for the body of the mother, need to happen an immunomodulation and tolerance that allow the placenta to go inside the uterine wall and invade all the uterine arteries. Okay? With that invasion, when the immune system of the mother allow that invasion, it creates a big space with low resistance and high flow. Okay? And these cells that are the natural killers of the mother, that are very, very high activated before the pregnancy, because these cells recognize the foreign bodies, they recognize the infections, and they kill everything that is not the mother's body. During the pregnancy, they are unactivated. They are sleeping. So they cannot recognize the placenta as a foreign tissue, so allow the placenta to go inside, to enter inside, and open the spiral arteries, that are the arteries from the uterus. So as a result, we have, in a normal pregnancy, low BPs, because there is a very important opening here for the arteries. So the flow can pass very slowly without increasing the blood pressure. By the other side, in a preeclamptic patient, the process of placentation is different. Why? Because the natural killers doesn't work very good, and they recognize the cells of the mother and start like an inflammatory process, because they are recognizing the placenta as a foreign body. So this inflammatory state makes an incomplete invasion of the spiral artery, and also a very little opening in the artery. So this flow, it's going to be a flow of a little diameter and a high resistance. So the flow is going to be not too much for the baby. So the placenta have to increase the pressure to to achieve the goals of flow for the baby. So here we have a comparison between the normal pregnancy and the preeclampsia placentation. And as I said to you, we have this problem, that in the preeclampsia placentation, there is a very little diameter of the communication of the pipes. But the pipe here is very wide, very big. So in the preeclampsia situation, the narrow pipe that we are marking here is very little, but there is no problem before the 20 weeks of pregnancy. Hakuna Shida. Why? Because the fetus is very little and it's not growing very fast. So the placenta in this little pipe can afford the flow without increasing the pressure, so there's no problem. But after the 20 weeks, the fetus is bigger, it's getting bigger, and it's growing very fast. So it needs more and more and more nutrients, and the placenta, when have preeclampsia, cannot afford, because this is very little. So this little flow needs to increase. So the placenta, for increase the pressure. And the increasing of the pressure make all the problem that we're going to look forward in the next slides. So as I showed you before, in this image, we have a baby in a mother with preeclampsia, that before the 20 weeks is everything okay. The baby is not hungry. But in the 20 weeks, the baby now is not getting all the food that he wants. So he's asking the mother, I want my 3-cheese pizza with extra ranch sauce and everything. But the placenta cannot afford. What happened? The placenta starts the secretion of vasoactive mediators that are like little hormones or little proteins that are very active and affect the vessels to increase the vasoconstriction and the pressure. So increasing the pressure, they can increase the flow in this little pipe. What happened? Increase the blood pressure, so they can increase the fetal nutrition. The fetus continue growing well, but we have endothelial dysfunction. All these vasoactive mediators, the increase of the blood pressure, make changes in the endothelium, and also these vasoactive mediators that are here not affect only the placental vessels, also affect all the vessels of the system of the mother, like the vessels in the kidney, in the heart, in the lungs, in the brain, in all the places. So that is the reason why we have a multisystemic disease. So we have in another stage the organ failure that can be in all these organs that I showed to you and also in more organs because the endothelial dysfunction is in all the endothelium. So all the organs that have endothelium can be affected, but these are the principal ones. The important thing here is that all this process can be asymptomatic. So the high BP can have no symptoms. The endothelial dysfunction can have no symptoms. And this process it's progressive, so it can go worse and worse and worse, and then it can have symptoms. But we have been like 2 or 3 months with a mother without symptoms, getting bad things for all the organs. Here, I make this timeline only to summarize and to emphasize in what happened in the preeclampsia since the conception until the birth. So since the conception until the week 15, there's no problems, no trouble. From the week 15 to 18, it's important to recognize the first important process, that is the bad placentation process. Okay? And the second important process to recognize is the second one, that is the organ damage failure process. So these two processes are very important to recognize. Why? Because in the process of bad placentation, we can act and we can prevent preeclampsia, making a treatment in this period of the pregnancy. So for persons that have a more risk to develop preeclampsia. We're going to talk about that later, but it's a treatment with aspirin to prevent the bad placentation and make like a better invasion of the cells of the placenta through the arterial walls of the mother. The second process is also very important to know because it's the process of organ damage failure. This process have two different sub-processes. That is the asymptomatic part, that is here, and the symptomatic part. Okay? Why is important to know the asymptomatic part? Because if we know that this process, the asymptomatic part, exists, we can be able to detect the preeclampsia early. If we have a very good control with the antenatal care, we take the BPs all the month or twice a month, it's very good because we can detect early the preeclampsia and we can act, we can monitorize the patient, we can do some treatment that can be better for the patient and also for the fetus. So in summary, to know the bad placentation for the prevention of preeclampsia and to know the organ damage failure process, especially the asymptomatic process, for the early detection of pregnancy. So now we have seen what is preeclampsia and what happened, what is the pathophysiology, and now we're going to continue solving the question how to diagnose and how to classify the preeclampsia. So how to diagnose preeclampsia? According to the Kenya national guidelines from the Ministry of Health, there are two key concepts to diagnose preeclampsia. The first concept is hypertension, the second concept is proteinuria. Hypertension we're going to define with this image. So in the next slides of the presentation, if you see this image, it means this definition, okay? That is elevated BPs over 140 with 90 in 4 hours apart, or elevated BPs over 160 with 110 minutes apart, okay? Here we take minutes to measure again because if we wait 4 hours with the mother with this blood pressure, the mother can have a serious damage. So it's important to treat it. That is why we only have to wait minutes, okay? And it's very important to know that there are some things that can make this, the mother have high BPs, but not because of the disease. For example, the caffeine, if the mother take coffee, or if the mother take a lot of amounts of tea, or for example, if the mother walk a lot, walk from Kibera a lot, like 5 kilometers walking pregnant until she came here to the hospital, we make a measurement of the BP, it can be increased. So we need to ask the mother to wait a little, to rest at least 10 minutes, and after that we can measure the blood pressure. After the blood pressure, as I said to you, is the proteinuria. There is another definition that is very important. This is the image that we're going to use to define proteinuria during all the presentation. And it can be defined according to the Kenya guidelines in 3 different ways. Proteins of 300 milligrams or more in 24 hours urine collection, that is not in our hospital. a creatinine and protein ratio of 0.3. This is also not in our hospital, and the dipstick reading of 2+. That is the only chance that we have to diagnose proteinuria in our hospital, so it's important for us to know. This exam is made with this thing that is a dipstick. We put it in urine, and then we measure with the colors in the envelope of the stick, and we compare if the urine have or doesn't have proteins. So here we have the classification of the whole day hypertensive disorder: gestational hypertension, preeclampsia, chronic hypertension, and chronic hypertension with preeclampsia superimposed. In the preeclampsia and the chronic hypertension with preeclampsia superimposed, we can subclassify this in the severity: without severe features, with severe features, and emergency. Okay, the same here. So with this classification, why is so important this classification? It's important because with that we assess the risk of the mother. And in all the patients with preeclampsia, we need to make a balance between the risk of the mother and the risk of prematurity of the fetus. Why? Because we need to planify for the delivery. That is the only definitive treatment for this disease. So we're going to start with the gestational hypertension. How we diagnose this? With a mother over 20 weeks that we're going to symbolize with this, with hypertension, that we define what is hypertension, and without proteinuria and without any of these severe features. So mother over 20 weeks, new hypertension. She cannot have previously hypertension. It's a new hypertension, and without a new proteinuria. Okay, and you need to rule out all of these things. So these mothers that you are thinking that they have gestational hypertension, you cannot, if you saw one of these mothers in the MCH and you do proteinuria and it's negative, you cannot confirm that it's gestational hypertension. You need to take the exams to rule out all these other things: the renal impairment, the liver impairment, the lungs. So it's very important to know that, because some people think, no, if the mother have a negative proteinuria, the mother is okay, she only have gestational hypertension. But if the mother have negative proteinuria but she have high BPs, it's important to refer her to the hospital because she needs to take further exams. Now, how we diagnose preeclampsia? Preeclampsia we diagnose with 3 important things. That is, the mother over 20 weeks of pregnancy, the new onset of hypertension, and new onset of proteinuria. Those 3 things are the classical way to diagnose preeclampsia. But also, if we don't have proteinuria, we can diagnose preeclampsia with the mother and the pressure, but with a new severe feature that can be thrombocytopenia, renal insufficiency, impaired liver function, or pulmonary edema, or cerebral or visual disturbances and symptoms. In the case of the pregestational hypertension or chronic hypertension, that is the same, is the opposite. There is a mother that have previously diagnosed with hypertension, or she doesn't have the diagnosis, but she had high blood pressure in the first ANC visit before the 20 weeks. So it's a mother that is pregnant, but is not with the big stomach because she is before the 20 weeks. And she have high blood pressure. But when you make the proteinuria, there is no proteinuria, or it can be a little of proteinuria that she have from a long time ago because of a renal disease or something. But there is no frank proteinuria. Okay? It's very important to rule out, as I said to you before, the thrombocytopenia, renal insufficiency, impaired liver function, all of that. So there is a reason why all patients with high BP, we need to refer to the hospital, or we need to refer to a higher complexity level to make exams. Okay? It doesn't have to be a hospital, but sometimes has to be. And in the other way, the chronic preeclampsia with superimposed chronic hypertension is a situation when we have a mother with hypertension before the 20 weeks, but after the 20 weeks, in addition of the hypertension, appears proteinuria or any of the severe features that we were talking about previously. So now we know how to diagnose all the different types of gestational hypertensive disorders. Okay, so after that there is another subclassification that is of severity in all the preeclampsia, so it can be here and here. This classification have three important types: the preeclampsia without severe features, the preeclampsia with severe features, and the preeclampsia with emergency features. This will be very important in the future. Why? Because we are going to talk about the interruption of the pregnancy, and we need to know the severity of the preeclampsia before deciding when to finalize, when to end with the pregnancy. So what is preeclampsia with severe features? According to the American College of Obstetrics and Gynecology from 2019 bulletin, the severe features are 6. The first one is the blood pressure. So if we have systolic over 160 or diastolic above 110 in 2 occasions, we can say that this mother has a severe feature. If the mother has thrombocytopenia, that is less than 100,000, also a severe feature. If we have a liver impairment, that can be a biochemical liver impairment with the twice above the normal LFT, or a clinical liver impairment that can be epigastric pain, but have to be a continuous pain, a pain that doesn't go with drugs, and also a pain that haven't another explanation. We can say that is a severe feature because of liver affection. In the case of the kidney, the severe feature is progressive renal insufficiency that can be creatinine of over 1.1. In the case of Bagari laboratories, that we have another unity, I calculate, and it's 97. So if the creatinine is upper to 97, we can say that is a severe feature. Also, it can be when the creatinine is twice the normal level, but it's not very common to have the normal levels of a mother. Okay, and also a clinical way to assess this, it can be oliguria. So if the mother said to you that she's urinating a little bit, you have to be aware of that and think that maybe she can have a severe feature. The next one is the pulmonary edema. The pulmonary edema, the only way to diagnose this is a clinical. So you need to auscultate the lungs. You need to check how is breathing this mother, the breathing pattern, to check if she have a pulmonary edema. Okay, and the sixth one is all the things that have to be with the neurological system and the eye. So new onset of cerebral or visual disturbances, it also can be a severe feature. It can be a stroke, it can be alteration of the sensorium, a lot of different things that cannot be explained by another cause, is considered as a preeclampsia with a severe feature. So, in the other way, what is a preeclampsia without severe feature? It's a preeclampsia that doesn't have anything of this. So how do you diagnose a preeclampsia without severe features? You need to make a complete clinical history, physical examination, and also take a lot of different blood exams to rule out all of these 6 things that are part of the severe features. So we have talked about preeclampsia without severe features, with severe features, and now we're going to talk about the most serious one, that is the preeclampsia with an emergency feature, an emergency condition. This part of the classification is very important because this means that the risk, the mother's risk, the mother's life is in a very high risk. Okay, I leave this presentation, this slide for you, but I summarize all of this, that is a lot of information, in this slide. Okay, so these conditions, all of these conditions are conditions that put the life of the mother in danger. So we need to finish the pregnancy to save the life of the mother, not to save the fetus. So here we don't care about the gestational age. If we are in front of one of these situations, we need to finish the pregnancy. Which are these situations? First, uncontrolled BP above 160 with 110, uncontrolled with in a long period of time without the maximum doses of 2 combined hypertensives, antihypertensives. Secondly, the dysfunction of the kidneys or the lung or the heart. Then the HELP and the eclampsia that we're going to look about each one of these separately. Then the placenta abruptio, that is a complication that can occur for the eclamptic patients or preeclamptic patients. That is not very common, but if this happens, the life of the fetus is in danger and also the life of the mother is in danger, so you need to finish the pregnancy. Also, there are symptoms that can be classified as an emergency condition. For example, the epigastric pain that the mother have for the classification of severe fetus. If the epigastric pain is constant and it doesn't go away for a lot of time, we can diagnose that is an emergency condition. Also the headache or visual disturbances or motor deficit, because all that things are reflecting that is a serious condition happening. For a mother to have symptoms that doesn't go away with magnesium sulfate and doesn't go away with controlling the BPs, it means that the preeclampsia is very advanced. So you need to take that symptoms as an emergency condition and finish the pregnancy. So what is the HELP syndrome? It's an acronym that is talking about a complication that occurs in preeclamptic mothers, that is intravascular hemolysis, elevated liver enzymes, and low platelet count. If we have all of these features, we're talking about HELP syndrome. If we have two of them and not one, we talk about incomplete HELP syndrome. Okay? The HELP syndrome complete itself is an indication of finishing the pregnancy regarding, doesn't matter the gestational age. Also, this syndrome can be presenting without high blood pressure, so sometimes we need to be aware of that, and if the mother have epigastric pain, if the mother have another severe features of preeclampsia without high BPs, we need to ask for the laboratory to rule out a HELP syndrome. So the normal progression of a preeclampsia, if you don't detect it on time and you don't treat it on time, is to develop an eclampsia. An eclampsia is the end part of the disease that is characterized by generalized tonic-clonic convulsions and coma. It occurs 50% of the time before the partum, 30% of the times during the delivery or during labor, and 20% of the times postpartum. The treatment to this at the initial moment, in the first moment, is of course ask for help and prevent the maternal injury. You have to take care of the head of the mother, put something soft surrounding the head, a cloth or a mattress or something, because she can hit the head, and place her during the convulsion and after the convulsion in lateral decubitus position. That is a position that is safe for her because she will not swallow her tongue, so she will breathe normally in that position. Okay. Also give oxygen and monitoring vital signs. Give magnesium sulfate to prevent a new eclampsia, and also treat the high BPs and everything if they are not on the target. And after the stabilization, you have to deliver before 6 hours, because this is an emergency feature. Okay, the mother can be very good after stabilization. The mother can be again very good, she okay and everything okay, but this is an emergency features, so you need to finish the pregnancy once you have the patient stable. So here with this picture, I make a summary about the classification of the severity of the preeclampsia. And why is so important this classification? Because of the treatment that we're going to see in a few slides more. But it's very important to know that if we have a patient without severe features, we need to rule out emergency features. We need to rule out everything. If we have a person with an emergency features, we have the diagnosis done. So we need to go ahead with the treatment. That is, end the delivery, end the pregnancy. And if we have a preeclampsia with severe features, it's also important to rule out all the emergency features, because she can have an ongoing emergency feature. So now that we know how to diagnose the preeclampsia, how to classify the preeclampsia according to the severity, like without severe features, with severe features, and in an emergency feature, we are going to be able to use this balance to know when we have to finish the pregnancy. So, first, in the preeclampsia without severe features, the risk of the mother is very little, because she doesn't have any severe features, she is okay. So you continue monitorization of the mother and of the baby, but you can wait for the interruption of the pregnancy at 37 weeks or term. In the other hand, in the preeclampsia with an emergency feeder, the risk of the mother is very, very high. Actually, the mother is almost dying. So in this situation, we need to perform an interruption of the pregnancy always. But in the preeclampsia with severe features, we have a mother that is not dying, but also is in a very important and serious condition. What do? This depends on the gestational age. If the gestational age is under 34 weeks, it means that the risk of prematurity of the baby is bigger than the risk of the mother. So we do conservative management and we give steroids because we have time. That steroids can help us because this mother can get worse in any moment and we will have to interrupt. This mother can change from a severe feeder to emergency. And if this mother change, we need to finish the pregnancy very fast. So we give steroids to be prepared in the case that we need to do that. In the other hand, if the baby is 34 weeks of gestational age, we have more time, we have more risk now for the mother than for the baby. So we finish the pregnancy. So now that we have seen what is preeclampsia, the pathology, how to diagnose the preeclampsia and how to classify, we're going to talk about only one slide about the preeclampsia prevention. So this slide is very important and I want you to take home because this is a thing, this is an issue that most of the people forget in all the antenatal care system, but if you can remember this will prevent maybe a lot of preeclampsias. So what about preeclampsia prevention? The preeclampsia prevention is one thing that you do that works before the developing of the preeclampsia, that works in the moment of the placentation. Do you remember this photo that I showed to you in the beginning of the presentation? In the process of the invasion of the arterial vessels, in that moment, the preeclampsia develops, but it doesn't have symptoms until very late. But if we act in this moment, giving low dose of aspirin, every day, one time a day, a low dose of aspirin between the 12 weeks or the 28 weeks, we can prevent the developing of the bad placentation and also the developing of preeclampsia. Okay? This is highly recommended by the American College and it's very important to do it. But how do we know which patient is going to develop preeclampsia and which patient is not going to develop preeclampsia? Well, we do this with risk factors. So we give this treatment only to the patients that have one high risk factor or two or more risk factors. So we need to assess our patient with this information. Does the patient have personal history of preeclampsia? Does the patient have an actual twin pregnancy? Or does the patient have previous disease like chronic hypertension, diabetes, kidney diseases, or autoimmune disease? Any one of these by itself, by its own, can be an indication to give this mother low dose of aspirin every day. And this has to be done by a general practitioner, a clinical officer, a nurse that is working in antenatal care. Okay? This doesn't have to be done by a doctor. So if you recognize any of these, you are authorized to give low-dose aspirin. On the other hand, we also have moderate risk factors that can be nulliparity, obesity, familiars with relatives with preeclampsia, or African race, that here in Africa most of people have this race, and 35 years or older. So this is very important because if the patient have two of these, also have the indication of giving the aspirin. The reduction of the global preeclampsia with this aspirin in the studies was not a big reduction. Not all the women prevent the preeclampsia, but it was very effective to prevent the developing of severe features. And the severe features are the things that have the mortality and the morbidity. So this is not to prevent the developing of preeclampsia. This is to prevent the severe features and the mortality associated to that. So if we give this to some mothers, maybe the mothers will develop preeclampsia, but maybe that matters if we doesn't give the aspirin, they would have developed a worse preeclampsia than with giving with the aspirin. I don't know if you get me. I have a very bad English, but I'm trying. Now we are in the middle of the class. We have seen what is preeclampsia, what happened with the preeclampsia, how to diagnose and classify the preeclampsia, and the preeclampsia prevention. I know that this class is very big, very long, and also very complex to understand. So if you are tired, if you are feeling that you don't understand, I invite you to put in pause the video, take a walk, go to eat something. Maybe you can rest and continue another day. But if you feel like you're not understanding well or you are very tired, don't continue the video and rest. That is very important for you because this video is very long. I hope you remember this slide. This slide that I used in previous presentations to talk about the systematical approach. That is very important to have an order when you are in front of a patient, and because the patient doesn't come to you with the diagnosis here in the face. Oh, I have preeclampsia, please treat me. No, the patient have a complaint, the patient have a symptom, and they want to know what they have, but they don't know, and also you don't know. So you need to approach the patient like this pyramid. You need to first make a good clinical history, a physical examination, and other further tests to have the diagnosis. In the case of the preeclampsia, we need to do this test to all the patients. So I first want to start this part asking to you, which is the minimal laboratory study that you need to ask for a patient that you are suspecting preeclampsia, or you have the diagnosis of preeclampsia. Like all the labs, the lab test or the image test that you need to take for this patient, I need you to please put in pause the video and write it down, all the things that you think, and after that you're going to look what is the correct answer to check the minimum exams that you need to ask if you know it or not. Well, here we have in front all the tests that we need to take, the minimum test that we need to take for a patient that we are suspecting preeclampsia. That is full hemogram, urine electrolyte and creatinine, liver function test, LDH, urinalysis, group and cross-match. That is the answer. Why the full hemogram? What do we need to look? The platelets of the HELP, they change in the HELP syndrome. The HB that change in the HELP syndrome because it comes down, and also change in the preeclampsia because it can be also hemoconcentration. The red cells, the creatinine to assess the renal function, the liver function test also to assess the liver function, and the bilirubin that increase in the hemolysis and also increase in liver insufficiency. The LDH is an enzyme that increase in the hemolysis because it's an intracellular enzyme. It's inside the red blood cells. When the red blood cells are breaking because of the hemolysis, the LDH increase over 300. The urinalysis also is important to assess the proteinuria, and the group and cross-match in the case that the patient needs to, for example, go to an emergency CS, or in the case that the patient needs transfusion because she starts bleeding a lot, or she started with a DIC and she needs fresh fluorescent plasma, etc. So which is the assessment? How do we approach this patient? First, in the clinical history, it's very important to ask about all the risk factors that I showed to you in the presentation, in the slide of the PET prevention with the aspirin. So you have there. But it's important to ask if she had in the previous pregnancies preeclampsia, if this pregnancy is a twin pregnancy, to assess if she had chronic hypertension or any other disease previously before the pregnancy, and you have many more. After that, the severity symptoms. It's very important to assess that. So you have to ask the patient if she have visual disturbances, epigastric pain, seizures, confusion, fetal movement perception, also to assess the fetal status. And important, very important, and most people can forget, is the ANC visit. Ask the mother if she came to all the ANC visits, if she have the BP records, to check. Maybe she have normal BPs, but almost in the limit, like 135 with 88, something like that. That is a signal that the mother have this disease, the preeclampsia, developing since a lot of months ago, and she was only in the asymptomatic period. Important to ask if she received the prophylaxis, also to assess the gestational age with the LMP and the ultrasound, and to check the concordance between the gestation by date and the gestation by scan, because maybe we are in front of a intrauterine growth restriction. Here I give you a table with a lot of different symptoms and signs that are present on preeclampsia. This table is taken from a guideline, a Kenyan guideline from the Ministry of Health, so it can be useful for you. I'm not going to read all of this, but I want you to have it on this presentation. Only important to know that these are the signs and symptoms, but most of the preeclamptic patients can have any symptoms, can be asymptomatic. So it's important to take the BP to all the women, not only for the symptomatic women. It's important to take the BPs for all the women in the ANC. So in the correct order, after performing a perfect clinical history, we have to make a perfect physical examination. This exam also has to be ordered, starting by the general physical examination with the ABC, checking if the airway is permeable, if the patient is breathing, the pulse, the circulation, the general neurological status, emphasize especially in the blood pressure, to check if there is pallor, edema, jaundice, respiratory pattern. All of these things can appear in a patient with help. For example, the jaundice and pallor, the edema also is a characteristic of preeclamptic patients. And if the patient have, for example, the emergency of pulmonary edema, she can have respiratory pattern alterations. When you go segment by segment, you start with the cervicothoracic segment, checking if there is jugular ingurgitation that can symbolize, for example, a heart attack, like a heart insufficiency. Also, heart and lung auscultation to check if there is liquid in the lungs, there is edema, pulmonary edema. Also to check per abdomen, specifically to check if there is epigastric tenderness, to do the Leopold as usual, to check if there is uterine dynamic, and also between contractions, if the patient is in labor between contractions, to check if there is uterine tenderness, because that can be because of a abruptio placenta. That is a common complication of this patient. Also to check the fetal heart rate, to check the viability. In the musculoskeletal part, it's very important to check the deep tendon reflex that are increased in the intensity and also are increased in the reflexogenous area. That is where the reflex can be started. If there is a wide and big reflexose area, is a sign that the sensorial part of the patient is very excited, hyperexcitation of the reflex. Also to check if there is edema in the extremities, and the genital exam to check with a speculoscopy or vaginal examination, depending on the situation of the patient. If there is a PV bleeding, you cannot do a vaginal examination, or if the patient is in preterm and is not in labor and is everything okay, you don't have to do a vaginal examination. You only practice a speculoscopy only if you need it. It's according to the situation of the patient, okay? But it's important to know that maybe in the future you will have to do that to assess the cervical conditions in order to finish the pregnancy. And the last part is all the other tests that we need to add to have this information about the patient, that we talk about that in the previous slide about the question. It's important to know the ultrasound, to know the estimated fetal weight, the amniotic fluid index, the gestational age, of course, is very important. And all of this So now we have seen these 4 topics, only remaining 2 topics that are about treatment. So which are the pillars of the management of preeclampsia? Please put in a pause this video, try to think by yourselves, write it down. There are 5 important pillars that you need to write in the paper, and after you write it, you can put play on the video again to check if you are okay. These are the 5 important parts of the treatment of preeclampsia. If we forgot one of these treatments, one of these pillars of the treatment, the whole building can fall down. So the preeclampsia is this building, and the treatment is in order of importance, not of importance, in order of on time. The first pillar, that is the first thing that you have to do, is control BP. The second pillar, the seizure prevention with magnesium sulfate. The third pillar is to monitor the maternal and fetal well-being. That must be during all the duration of the hospitalization and during all the duration of the disease until 6 weeks after partum. The fourth pillar is to monitor fetal well-being. And the fifth pillar, that is the most important, is to plan for the delivery. The one that we always forget is the fifth pillar, and it's the most important. Why we always forget it is because there is a lot of preeclamptic patients, and sometimes we can act like robot. We can act like robot, like this. Like we see the preeclamptic patients, we do all of the, from 1 to 4, we do all of this, we do very good because we do it automatically. We do the same for all the patients. But the fifth pillar is different patient to patient, depending on the severity, on the situation, on the gestational age. So to do this pillar, we have to think a little more. If we are like robots, and we only act like doing the from 1 to 4 all the time, all the same in all the patients, of course we can do from 1 to 4, but we couldn't make the fifth part of the treatment, that is the plan to delivery. And it's the most important part of the treatment because it's the definitive treatment. Okay, so I invite you to don't be like robots. I invite you to stop and think in every patient, every situation, about the gestational age, about the severe features, about the monitorization, to check, to think if this patient needs to be delivered now, needs to be delivered in 2 days, in 2 weeks, or when. That is the most important part of the treatment, I repeat. So first, the BP control. We have 2 different ways to control the BP. When we have the BP control with oral therapy, that is when there is no severe features, or the IV therapy with severe features. So about the oral therapy, we can control the BP with methyldopa, nifedipine, and hydralazine. These 3 drugs are authorized to work on pregnancy. If there is a mother that is using any other antihypertensive, you need to take it away. For example, enalapril, losartan, okay, atenolol, all those antihypertensives, they are not recommended in the pregnancy. So we need to use these 3. The methyldopa is a central effect, and the dose can go up to 1 gram 3 times daily. You can go titrating that. It doesn't have important adverse reactions, and it's a very safe drug. The nifedipine is a calcium channel blocker. The dosage is from 10 to 20 milligrams BD, can go up to 40 milligrams BD as a maximum dose. The principal adverse reaction is the headache, okay? And the hydralazine is 10 or 25 milligrams BD, can go up to 50 TDS. It's a nitrate, it's a smooth muscle relaxator, and it's very good to control the BPs, but also it has the adverse reaction of hypotension. But this adverse reaction is most common in the IV formulation. Okay, so the important to manage, like the most common for use, are these 2, the methyldopa and nifedipine. Usually, with both of these in a mild level, quantity doses, you can control a BP. But there are some times that you need the maximum dose in both of them, and you cannot control, and that means an emergency. So you need to take action. Here is a photo of the nifedipine of 20 milligrams that we have in our ward. Only for you to know that that is the drug and the formulation that we use in Bagari Hospital. So after the oral therapy, or if the patient doesn't need a oral therapy because the patient is with severe features, the patient is with high blood pressure and you need to down the pressure very fast, or for example the patient is not with high blood pressure but the patient is without unconsciousness, for example eclampsia or something, you need to give IV drugs. The patient cannot swallow. You have to use IV antihypertensive. The unique IV antihypertensive that we have is hydralazine, that is a formulation of 5 milligrams. You give it in a, how do you give it? You have to give it in a slow IV infusion for 15 minutes. Repeat the blood pressure 15 minutes after you finish that infusion. And if it is still high, you have to repeat again. So you give 5 milligrams during 15 minutes. Wait 15 minutes. Take again the blood pressure. If it's high, you give again during 15 minutes, 5 milligrams. Then wait 15 minutes again, and then check the blood pressure. You can repeat that only 4 times because the maximum dose is 4 doses. Okay? If you cannot control with that, it means you're in trouble, you need to finish pregnancy. The other and the most recommended antihypertensive and the most safe antihypertensive and the most effective antihypertensive is labetalol. I'm not going to talk about how to give that because we don't have it in Bagari. But if you cannot control with the other drugs, you need to scale to that and you need to ask the patient to buy this drug, but it's very expensive. The other thing that we have is the per-oral nifedipine that we also use during the severe features preeclampsia, because the hydralazine alone is very difficult to manage and also is very fast action, but also fast release of the action. So the nifedipine is more stable and also is more easy to control. You have to give 20 milligrams and repeat after 30 minutes. You can repeat that dose till a maximum daily dose of 180 milligrams. So the second important pillar of the treatment of preeclampsia is the magnesium sulfate treatment. This is the most important drug and is the queen of the prevention of the preeclampsia. There is a study called the MAGPIE trial that compared the treatment with magnesium sulfate versus placebo in preeclamptic women with severe features. This is a very well-known trial, very important trial that is multicentric in different countries, developed and non-developed countries. And the results of the study say that the magnesium sulfate decreased the risk of eclampsia to the half. Also decrease the risk of placental abruption. This is not only seizure prophylaxis. You help in all the things. Also decrease the risk of maternal mortality and decrease the risk of perinatal asphyxia in the situations that we have fetuses below 32 weeks. So it's a neuroprotector also for the baby. So all the things are the benefit things about magnesium sulfate. That is the reason why it's so important to give the magnesium sulfate. So how do we give the magnesium sulfate? The first question is when. The indication of magnesium sulfate is for all the patients that have preeclampsia with severe features, and you have to give from the detection, from when you detect the severe fetal until 24 hours after the delivery or after the last seizure event. So if the mother have a seizure after the delivery, you count 24 hours after that seizure, not after the delivery. When not to give magnesium sulfate? When the patient is in anuria, because the magnesium sulfate is metabolized by the kidney and it's expelled by the kidney. If the kidney is not working, you are going to start an accumulation of magnesium sulfate in the body and can reach toxicity levels very fast. That is the reason why we cannot give magnesium sulfate if the patient is in anuria. Okay? Also, there are some precautions that you need to take, that you have to stop the magnesium sulfate if the respiratory rate is under 16 respirations per minute, or you have to stop it if the urine output is less than 30 ml per hour during 4 hours. And how to give the magnesium sulfate? In a few slides more, we're going to talk about how to give it like more precisely. But there are two different regimens. The intramuscular regimen, that is the pre-char, that is the regimen that we use in Bagari Hospital, and also the intravenous regimen. The intravenous regimen, sometimes we have in Bagari Hospital, but sometimes we don't have. First, I'm going to talk about the intravenous. The loading dose is 4 grams IV during 15-20 minutes, and after that you give 1 gram or 2 grams per hour in an IV infusion. And the intramuscular regimen, you can check it in a chart that is pasted in the obstetric ward. It's pasted there, and it's very easy to understand. It's based in the recommendation of the Ministry of Health, and in that chart you have all the information about the adverse reaction, when to stop the infusion, what happens if you have a seizure, what do you have to do. So I invite you to read that chart, also take a photo like me, and having your phone, in the case that you're working in another place, you can use it. How to prepare the magnesium sulfate infusion in Bagari? As I said to you, the most common thing is that we don't have the IV infusion, so we need to prepare the intramuscular treatment. And how we do it? First, we need to know how much grams of magnesium sulfate does one ampoule have. So every ampoule are of 10 ml, and in every ampoule we have 5 grams of magnesium sulfate. That is very important to know. So how do we prepare this? There are 3 steps. The first step is that you dilute 8 ml of this ampoule that are 4 grams of magnesium sulfate plus 12 ml of water for injection. You mix that in a syringe, and you give it IV in 10 to 15 minutes. That is the loading dose. This part, the step 1 and the step 2 are the loading dose, then the step 3 are the maintaining dose. So the loading dose have an IV part, that is this, the water for injection, and an intramuscular part, that is the step number 2. The step number 2 is 10 ml, is one complete ampoule of 5 grams of magnesium sulfate. You divide in 2 different syringes, and you mix with 1 ml of lidocaine at 2% in each, and you put one of those syringes in each buttock. Okay, that is the loading dose. In addition with the IV loading dose, and after that you have to give a maintaining dose of 10 ml, that is 5 grams, every 4 hours, and you go in every buttock alternating. So left after 4 hours, right, like that. If you are during the maintaining dose or in any moment and you have an eclampsia, it means that you have to start again the step 1, that is the IV magnesium sulfate in 10 minutes. You do that and the eclampsia will go. The most common is for the eclampsia is to be self-limited. So the eclampsia will end whether you give or you not give magnesium sulfate. But the role of magnesium sulfate here is to prevent the recurrence of a new eclampsia. That is why it's so important to give the magnesium sulfate. And the monitorization. I said to you that have a lot of different adverse reactions. The most common adverse reaction is hot flashes, that is related to the velocity of the infusion, and it's very common because the magnesium sulfate relaxes all the smooth muscles. So, of course, all the vasculature that was very vasoconstricted will relax and will create like a peripheric vasorelaxation that will develop rubor and hot flashes. The important precautions, the important adverse reactions that we need to monitorize are the respiratory rate, the urine output, because those are the things that can guide us to important problems. The overdose of magnesium sulfate have different manifestations in an order, so we are going to be able to detect them in that order, so we will be able to stop the infusion before the cardiac arrest. The first thing that happened is the abolition of the deep tendon reflex. After that, we have respiratory depression going like with decreasing in the respiratory rate, and also in the how deep are the respirations. Then we have oliguria, like kidney failure, and then arrhythmias, and then cardiac arrest. The management of this, when we feel like we have an overdose, is to give 10 ml of 10% of calcium gluconate. That is 1 gram of calcium gluconate IV in 3 minutes. Every ampoule of calcium gluconate have 1 gram, so you have to give only 1 complete calcium gluconate ampoule, and you are out of the problem. It's very important, this slide, because the magnesium sulfate is not a drug that we can give and we can go away, like to give in aldomate or to give paracetamol. The magnesium sulfate is a drug that is very difficult to keep in the therapeutic level, and you can easily go to toxic levels, or you also can easily go to under therapeutic levels. So you need to be aware, you need to give the patient the correct dosage, and also be very near the patient, checking all the time the urine output, so you have to put a catheter, and checking all the time the respiratory rate. So the third and the fourth pillar are very important and are the monitorization of the maternal and fetal well-being. When you are in front of a preeclampsia without severe features, it's important to check the estimated fetal growth with an ultrasound every 2 weeks, to check also the amniotic fluid index and the Doppler every 1 week, and close monitoring of blood pressure, fetal heart rate, the symptoms of preeclampsia, weekly laboratory test, fetal kick chart, and all of that things. Most of the times, I think always, it's better for the patient to be admitted in the hospital, because if you try to control it as an outpatient, maybe you can have problems. In the preeclampsia with severe features, it's not very clear how often you have to make all that evaluations, but it depends on the severe feature and the clinic of the patient, and of course have to be more frequently or the same frequently than this that I explained to you in the category of without severe features. The importance here is it's a decision of the doctor how often you have to check it. And in the emergency, you don't have to monitorize too much, because you know that you have to finish the pregnancy. So the important thing here is that you stabilize the patient, hemodynamically speaking, and also neurologically speaking. You stabilize the patient, wait until the seizure finish, for example, and you have to finish the pregnancy. So here you don't have to do so much monitorization. You have to do a lot of treatment. You have to finish the pregnancy, induce. But during all the time that you are with the patient, and you, for example, decide to induce per vaginal, you have like 6 hours with the patient in this category of emergency. You need to be very near the patient, and the monitorization must be very closer. So which are the risks for the fetus with the preeclamptic mothers? First, the intrauterine growth restriction because of the placental insufficiency. Secondly, the placental abruption, that is it's a very serious complication. It's not so common, but it's very serious, and most of the time finish with the intrauterine fetal demise. And finally, the most important and the most preventable, the most treatable condition is the preterm delivery because of an indication of the finishing of the pregnancy. So in this situation, we need to be aware, prepare for a neonatal resuscitation, and also prepare to have a hospital that have an MBU, that have the facilitations to treat these patients. Also try to perform a long maturation with steroids as long as we can, in order to also save the fetus. So the fifth pillar, and the most important because it's the definitive pillar, is the plan for delivery. Here is the moment when we have to think more. Here we can make the difference. So we don't have to be robots, or if we are robots, we have to think in the balance. So if we have a preeclampsia without severe features, finish pregnancy in 37 weeks. if we have a preeclampsia with severe features, depending on gestational age, we make conservative management and give steroids before 34 weeks. We finish the pregnancy after 34 weeks. And if the preeclampsia have emergency features, we have to finish the pregnancy always, at any time, and as soon as possible. So in this fifth pillar, which are the important things about the delivery? Is that when the interruption of the pregnancy is after 34 weeks of pregnancy, you should not delay the interruption because of the administration of steroids. But I recommend you to keep the steroids. The concept here is that you don't have to delay the administration, delay the pregnancy finishing only because you are waiting the 24 hours for the steroids. Because after 34 weeks, the fetus, the lungs of the fetus are more mature and better lungs than below 34 weeks, and the risk of the mother is too much. So you give corticoids and you start inducing labor, and maybe that corticoids can act during that hours before the birth, but you don't have to wait until 24 hours of corticoids to start the induction. That is the key message. Secondly, when you do a pregnancy finishing before 34 weeks, the steroids are recommended, okay? And because below 34 weeks, you know that the lungs can be worse, but the maternal or fetal deterioration may preclude the completion of the course of steroids. And also here, the important message is to know that we need to save the mother first. If we are not able to save the mother, of course, the mother and the fetus will die. So here, the first person to save is the mother, and after that, we think in the fetus. If we try to give steroids, but the mother is in a eclamptic, if the mother is with seizures and eclampsia, we cannot wait 24 hours. We need to finish the pregnancy now. The same happens with another emergency issues like HELP or, for example, pulmonary edema. During the conservative management, the delivery is recommended at any time if the deterioration of maternal or fetal conditions occurs. So here I have a question for you, because I think maybe you can be sleeping. This class is very long. So now I want you to think a little bit. How we supposed to deliver this patient? We know that we have to finish the pregnancy. So in average, which is the best way to deliver this patient? Is it an SBD? Is it an emergency cesarean section? Is the correct answer maybe the most comfortable for the doctor? Or maybe it doesn't matter? Or it has to be maybe a laparoscopic delivery? Please put in pause this video, and when you have the answer, you continue. So the correct answer is a simple vaginal delivery. So we need to make an induction of labor, okay? And the only indication for an emergency CS is when we have a contraindication of induction. For example, a previous scar, or for example, a breech delivery or something. But the preeclampsia itself is not an indication of cesarean section. Of course, the normal vaginal delivery have less complications, less bleeding, less pain. So it's better for us always to prefer the normal vaginal delivery.
Es spontaneous.
So now that we have a patient with preeclampsia and we have planned to induce labor to finish the pregnancy, we need to remember the words of our friends, Mr. John Njue. So now that you understand the VE, use my score, the Bishop score. So John Njue is the Bishop of Nairobi. I hope that you meet him. If you don't meet him, you have to check my other class, the seminar number 7 about labor conduction and monitorization. We talk about the Bishop score. That is a score that we use to assess the cervical conditions in order to know whether we're going to make an induction with oxytocin augmentation or with misoprostol. So after doing all of this score that we have here, we will have a score points of 6 or more, that is a favorable cervix, or below 6 is an unfavorable cervix. When we are in front of a favorable cervix, we give the oxytocin augmentation to start labor. We start with 10 drops per minute, titrating up, so the oxytocin will start uterine dynamic, the contractions will modify the cervix, and then the delivery can occur. When the baby is engaged, we can perform an artificial rupture of membranes. With that, we can have a diagnostic tool because we can check if the fetus is suffering or not, checking if there is meconium liquor stained or not. And also, in addition to a diagnostic tool, we also, it's a therapeutic tool because we improve the labor, we progress the labor with the rupture of membranes, we coordinate the uterine dynamic and all of that. Of course, it's very important to fill the partograph with a constant fetal and maternal monitorization, and of course the BPs and the maternal well-being must be very important because this is an ill mother, so we need to be very closely monitorization of that mother. Secondly, if the visual score is below 6, we have an unfavorable cervix. That means that we need to give misoprostol, that is a prostaglandin drug that make cervical modifications. So we give 25 micrograms per oral, and after 6 hours, if there's no modification or little modifications, we give another dose. In addition to that, we can start mechanical induction with a Foley catheter, and when the baby is engaged, we perform also an REM. Of course, the partograph, it's an important rule that it's for the two situations, and the monitorization is, of course, the most important thing to do here. So when we do a CS in these patients, when we have an unfavorable cervix that is very, very far away for delivery, like a very hard posterior and long cervix with no dilatation, maybe we try to skip the delivery by induction because we are very hurried with delivering this baby, for example, a seizure or a HELP syndrome that is very severe. We can do an emergency CS. A failed induction, that by definition, a failed induction is when there is no delivery after 24 hours of trying to induce a delivery. And another indication is, for example, any other complication like cephalopelvic disproportion, non-resurgent fetal status, malpresentation, or elderly gravida, or another different indications. So now we have finished to answer all of our questions about the preeclampsia. I hope you liked this class. I hope you enjoyed. Of course, you can ask me whatever you want. Now there is a few slides only to put in practice all of this, and I want to test you in different situations. So please put attention. This is the last part of the class, and it's the part of the key message of the class for you to take home. Here we have a situation, the situation number 1. You are working in Saola Clinic in Quivera. A primigravida with 36 weeks gestation by date came to the ANC. On the physical exam, you detect the blood pressure of 141/85. All the rest is normal. No visual disturbances, no epigastric pain, fetal movement perceptions are okay, and fetal head rate is 134 regular. In this situation, we have to refer. Please, I invite you to think a little bit about this. This is a mother that have only 1 point of systolic blood pressure high, and all the rest is normal. But I need you to think which is the best answer. Put in pause the video, and then you can continue to check the answer. The answer is yes. Of course, we have to refer. Any hypertension that we detect during pregnancy, it can be before 20 weeks or after 20 weeks, we have to refer the patient because that is a patient that potentially can have a preeclampsia and need to be categorized. We need to check if she has severe features or not, and to do that, we need all the installations of the hospital. We need to have ultrasound, we need to have a laboratory test, we need to have a consultant that can look for the patient or a medical officer. So that is very important. All the patients that have high blood pressure must be referred. Okay? Maybe there are some situations that the patient have taken caffeine, have taken tobacco, or have walked a lot, and she have only 1 point up. Maybe you can wait, make the patient rest, take the blood pressure again, and if the pressure is very normal, you can leave her home. But all of the situation, if you have the doubt, it's better to refer the patient, because the normal BP in the patients in pregnancy is like 110 with 80, 110 with 70. The normal is to be low pressure. So if we have normal or up pressure, we need to be aware. And when they trespass the limit of 140 to 90, we need to refer. The situation 2. You are working in the same Saola clinic in the first ANC of Mercy Adiambo, a 35 years old primigravida at 15 weeks gestation validate. She said, I am very healthy. I have only chronic hypertension, but since a lot of years ago, and well managed with a losartan. On the physical examination, there was nothing abnormally detected. So the question is, can you advise something important to this woman? So here we are in front of a mother that have history of chronic previous hypertension. She is managed with losartan, and she is starting the first ANC visit. She is in the period of placentation before the week number 20. So I invite you to check or remember the first slides about the pathophysiology, and also to remember the slide about prevention. Please put in pause the video and try to think which is the best alternative. Then you can check it with the results. So the correct alternative in this situation to folic acid and 1 milligram daily and to come again in 1 month is good because of the folic acid, but all the rest is like a normal pregnancy, so that is not the correct answer. Eat vegetables and ugali and don't do exercise, that also is not the correct answer. The ugali is very good, but for prevention of preeclampsia, there are no studies that support it. Decrease sodium intake and do exercise, that also is not the recommendation. So give aspirin 75 milligrams daily and discontinue losartan and perform an ANC visit with a consultant, that is the correct answer. Okay? So in order to prevent the preeclampsia, we give aspirin, because this mother is in very early pregnancy. So we can, with the aspirin, we can affect the placentation process in order to prevent the preeclampsia. Or maybe we cannot prevent the developing of preeclampsia, but we can make it to have less severe features than without aspirin. So it's very important. The other thing that is very important is to discontinue losartan. There are several important drugs in pregnancy that are forbidden. And from the antihypertensive family, the losartan, the enalapril, the atenolol are drugs that we cannot use. So that is the reason why we need to refer to a consultant for the ANC visit, and the consultant will start the schema of drugs, and also he will planify the follow-up of this patient. Okay, but the aspirin is a thing that we need to know when we have to give it. In this situation, we give because the patient have a lot of different risk factors. The race, because she's a Kenyan. Also, the previous chronic hypertension, that is a risk factor. And there are more risk factors that I forget, but please, I invite you to come back in the video and try to check it. And so that is the correct answer, the letter number D. And the letter number E, that is relax the patient, send her to the house and eat chapati, that is also not the correct answer. So thank you very much. I know that this class is very long, and it's a topic that is very complex, very difficult to understand. So if you have any doubt, you send me a WhatsApp or you send me an email. I happily will help you. And if I don't know, I happily can search the information or ask someone else. The message to take you to take home message are these 5 important messages. First, the placenta is the responsible for the preeclampsia. Okay, so never forget, the placenta is the responsible, so the definitive treatment is to take away the placenta, the delivery. In the meanwhile, we have to be aware and think about the risk of the mother and the risk of the fetus to take the decision. Secondly, the important message is that the organ damage failure occurs before the symptoms. So we need to detect early this disease. So here we have the importance of the antenatal care visits. In every antenatal care visit, it's very important to measure the blood pressure. And also, if we have something that we're suspecting high BPs or something, it's very important to refer these patients because they need to be assessed in a complete examination, as I said to you, in a systematical approach with the correct physical examination, the correct clinical history, and also the correct laboratory test. The third point is that the preeclampsia can be preventable and is possible. You can prevent it based on the risk factor. You assess the risk of the patient and you give aspirin to the patient that you think have more risk. And this is a thing that has to be done by all of you, not by the consultants. You are the doctors, you are the person that see these patients in the antenatal care in the first visit. And this prophylaxis with aspirin is very good when you give in the early pregnancy. If you wait until the week 20, the placentation process is done. So the preeclampsia is installed in the body of the woman. These have to be given in the first stage of pregnancy. And it's easy things to do. So you have to assess this patient. Sometimes are patients that you feel like they don't need treatment because they look very good. It's only a nulliparous woman that is black. Here we have two different risk factors, woman and black. And that is enough to give the aspirin. So please, I encourage you to do this because with this we can prevent mortality, we can prevent preeclampsia. The fourth point is to know that difficult decisions in treatment, and these difficult decisions are because we have two lives here, the life of the fetus and the life of the mother. And these decisions must be thinked depending on the gestational age and also the severity of the preeclampsia. That is where it's very important to know how to classify the preeclampsia and also to have a correct gestational age. And the last one is never forget the pillars of the treatment, the 5 pillars. I will make printed notes for you so you can have all that information printed. But please never forget and have always in mind the 5 pillars. Thank you very much. See you this Thursday.